All right, let's talk about disorders with the cardiovascular blood flow and peripheral blood flow. So we'll just get into it, and I'll talk first about just the different things that can happen that will damage the vessels, and then we'll get into the problems that can occur because of that damage. So arteriosclerosis, this is the only time you're really going to see us really talking about this as a main issue, but basically, it's associated with aging, and its counterpart is atherosclerosis, which you've probably heard about before in talking about cardiovascular issues. But arteriosclerosis, like I think I just said, it's more associated with aging. Okay, so this is basically where your vessels harden, they become kind of calcified. Sometimes there can be some scarring, but it's just really going along with aging. And the way that I remember atherosclerosis versus arteriosclerosis is that arteriosclerosis sometimes sounds to me more like deterioration, which happens over time. You know, it's not anything that you're doing to cause it. It just happens to you. But basically, when those vessels get really hard and they're not elastic and spongy and, you know, moving that blood flow through the way we want it to, it's going to decrease the ability of the blood to really flow through easily, which will then decrease the amount of blood that you're going to get to your major organs, like your brain, your kidneys, your heart itself, your lungs, everything. Okay, so we want our vessels to stay as elastic as possible, but sometimes, like we said, with aging, they don't. With atherosclerosis, this is something that is modifiable, which means we have control over that. Okay, a lot of times it's caused by our diets or our lifestyle or things like that. Sometimes genetics or your hereditary predispositions can lead towards atherosclerosis as well. You can have hyperlipidemia, which means excess levels of blood fat in your body that can then lead to these fatty deposits or lipid deposits within the vessels, and you'll see a picture of it, and it's nasty. It is truly nasty. But you can also see formation of plaque, which is just basically cholesterol that will lodge into the inside of the vessels and clog it up, like when you have a clogged drain because all that hair gets down there. I know, disgusting. But it's the same thing. It's whenever you get gunk inside vessels that don't need to have gunk in them, clogs them up, you'll end up having decreased blood flow to the rest of your body from those vessels being like that. It can also be linked to prior infections like pneumonia. You know, whenever you have inflammation to an area, platelets and, you know, the rest of your blood flows there to try to heal it and fix it, but you can end up having formation of clots in that area, and you just have buildup of plaque all throughout those vessels. And like I said, when you see the picture of this, you're going to really see it. But your CRP levels will be elevated whenever you have had a prior infection that has led to this problem. Remember, CRP is just telling us about generalized inflammation in the body. After an injury, also, like we said, the platelets can travel to try to heal it. They get trapped, form clots. And this is just a breakdown of how this all happens. So here's a picture of this gunk getting clogged up inside your vessel. That is not good, right? Because the more gunk you get clogged up in there, the less easily the blood can flow through those vessels. You can see here it's obstructed with plaque. And this is just fatty deposits that have settled within here because of this patient's diet and lack of exercise or whatever it is that they've done to themselves. So there are some non-modifiable, which means you can't change these risk factors, and there's also a whole list of modifiable risk factors that lead towards atherosclerosis. The non-modifiable ones are your age, your gender, which the male gender is more susceptible to developing atherosclerotic changes within the vessels, your ethnicity, and your hereditary predispositions. The modifiable risk factors are if you have diabetes, and that is acquired diabetes, not type 1 where you were born with it, hypertension, obesity, infection, alcohol abuse, and then hyperlipidemia. And that you get hyperlipidemia when you eat a high-fat diet. In class, we're going to watch this YouTube video, and I also encourage you to watch it on your own if you want to, but it's very interesting just to see how it all happens. One of the signs and symptoms that you have atherosclerosis is if you are experiencing intermittent claudication. And we talked about that the other day, where you have a lot of pain when you're walking around, but as soon as you sit down and put your legs up, it goes away. And that's telling you, hey, my blood is not flowing very easily through my vessels. And a lot of that is because of these atherosclerotic changes that are happening with the plaque buildup and scarring and everything. You'll see if you were to dissect or get a scan of your major vessels, you would see a fatty streak. And that's like a white streak all along that vessel. And that's because of the accumulation of the lipids and white blood cells through those vessel walls. Let's go ahead and talk about one of the most common, I guess, occlusive disorders that can occur because of atherosclerosis or arteriosclerosis. And it's coronary artery disease. And this is your basic major heart disease. Everyone is susceptible to this, so that's why we all need to keep up a high fiber, low-fat diet and just eat heart-healthy foods, exercise, keep up our cardiovascular, health and everything too. So coronary occlusion is what leads to coronary artery disease, and it's whenever you have closing of your coronary artery because of an interruption of blood supply for some reason. Like we said, it can be because of those arteriosclerotic changes where it's deterioration over time with aging with calcium deposits, or atherosclerosis where you've eaten a really high fat diet, high cholesterol, it all lodges inside those vessels. A lot of times it's not diagnosed until middle age or older age, but the changes can begin a lot earlier, especially if you have very, very poor health. The signs and symptoms can go unnoticed, especially if you lead a sedentary lifestyle, because somebody that is very active and is trying to work out their cardiovascular health as much as possible, then they're going to notice more quickly if they're noticing changes, or if their blood's not pumping the way that it should, they're not getting the oxygenation that they should. So for example, I'm going to use me as an example. I have a non-modifiable risk factor with my hereditary that has led to me having really high cholesterol. I work out regularly, but I have high cholesterol. And so what I notice sometimes when I've eaten something that's very high fat or high cholesterol that's led even more towards this problem, that I can't exercise as hard or as long. I feel winded more quickly. My heart sometimes has discomfort. And that's something that you can watch for even in somebody who's relatively fit, because a lot of times they have these things that have led them to not have a very healthy heart, okay? And I don't have coronary artery disease, but that's one of the predisposing factors. So that's something that, like we said, if they have a sedentary lifestyle, if I didn't go and run or swim or whatever, I might not notice for a very long time that I had any issue, until I had maybe a very high stress situation or some situation where my oxygen demand wasn't being met because of the issues within my vessels. Does that make sense? I hope so. Okay, so when you have coronary artery disease, you have an increased demand for coronary oxygenated blood flow, okay? And so then you start seeing some symptoms manifest because of that increased demand for the oxygenated blood. Because if you have all of those changes within the vessels, the amount of oxygenated blood that's traveling through is minimal at that point, because it's restricting. So you're going to start noticing some things within that patient. Obesity with apple-shaped bodies, these patients are at higher risk than people who have a pear-shaped body. And you can see this picture here. Apple-shaped bodies are people who have more of their weight that they're carrying above the waist, and pear-shaped bodies are the ones that are carrying most of the weight below their waist. Smoking does intensify your probability of developing coronary artery disease, and angina might be present as well. Some of the inherited risk factors, again, the male sex, type 1 diabetes, increased lipid levels, genetic predisposition, hypertension. Some of those things they probably can't control whether or not they get them, but they can control how it progresses, because even if they have increased lipid levels, they can eat a low-fat diet and exercise and do those things that they need to do to try to bring it down. If they have natural hypertension that they inherited from their ancestors, then they can, again, exercise, eat low-fat diets, and maybe even be on blood pressure medications to help reduce their high blood pressure and their hypertension, so that they don't do permanent damage to their heart. Now, behavioral risk factors, sedentary lifestyle, always. If you see somebody have a sedentary lifestyle, get them up off the couch. Tell them to turn off the television and just go walk around their neighborhood. Teach them to stop smoking, because that is definitely going to predispose them to coronary artery disease. Obesity, a competitive or aggressive personality, so somebody that is continuously angry, that's going to increase their blood pressure, and it's going to also cause them to potentially develop heart disease as a result of that aggressive and angry personality, and a high-fat diet, of course. So some signs and symptoms that we can see of somebody who has coronary artery disease: they'll feel very tired. They'll have some discomfort in their chest, especially during activity or stress. Sometimes you might see some atypical symptoms, especially in women, where their jaw hurts, or they feel really nauseous, or just kind of dizzy and feel like they have a barrel chest, or they just feel kind of strange, okay? And so we want to pay attention to all signs and symptoms, and don't overlook anything. We always want to inspect the heart anytime we notice any odd signs or symptoms with somebody's general health status. It's always important to assess your patient before you intervene as well. So take their vital signs. Ask them to describe the pain. Is it crushing, squeezing, tight? Does it feel heavy? Ask them to describe all of that. Ask them where the pain is located. Is the pain relieved by rest or sitting up, leaning over, any of those things? Some patients might present with signs that suggest hyperlipidemia, like obesity or hypertension. Their pulse might be really, really high when at rest, and irregular whenever they're exercising, or they might have this very strange phenomenon called xanthelasma. I can't say it, so I don't expect you to have to say that. But basically, if you see this plaque around their eyes here, you see that? Then that is a sign that they have poor coronary blood flow, okay? Coronary artery blood flow. So we want to pay attention to that, because that's telling us that there's something going on. These are fatty deposits that they've got there. And then you also might see arcus senilis, which is fat granule deposits in their eyes, and you see it by an opaque ring around the cornea. See this white ring around their corneas, which is also very strange and not normal. Okay. To diagnose it, we want to get a lipid profile. LDL is the bad. Cholesterol, it's low, low, low. Low density, bad. Okay, so when I think low, I think, oh, down in the dumps, bad cholesterol, right? HDL is the good, because whenever anything is high on the list, then it's good, right? So HDL is the good cholesterol. It actually carries out waste. It carries the cholesterol to the liver for removal, so it carries out the bad cholesterol and just helps to get it out of the body. We want the LDL to be below 100, and we want the HDL to be above 60. We want our total cholesterol to be below 200. So however we can work those numbers to where the HDL is greater than 60 and LDL is lower than 100, that's great. Triglycerides are also really bad parts of cholesterol, and we want those to be below 150. Okay, so remember these numbers. You are going to need to know them for your test, and you're going to need to know them for practice. So this is another, list of numbers that you got to memorize, but it's good to know them. Okay, you'll use these over and over and over again. The trick to determine the patient's risk is to divide their total cholesterol by their HDL. If the result is greater than 5, then they have a potential for developing coronary artery disease. So for example, I want you to work out on your own. If somebody's total cholesterol was 250 and their HDL was 50, what would their risk be? Okay, so figure that out. We're going to do problems like that in class. So 250 divided by 50 is, okay, I had a moment there for a second, but 250 divided by 50 is 5. It is 5. I know that I probably should be able to do mental math a little bit better, but I can't. So go ahead and take it from me that it's fine to use a calculator, and it's fine to have a little brain fart every now and then where you're going, wait a second, is that right? Is that right? Yes. Okay. So if their total cholesterol was 250, their HDL was 50, then the number is 5. Okay, so they're probably borderline at risk for developing coronary artery disease. All right, so a CT scan is going to show us the plaques, because when we get CT scans, we can actually visualize. If we get a stress test where they do an exercise induced stress tests where they hook them up to the ECG and watch them on the treadmill, it's going to reveal to us ST segment depressions or a dysrhythmia, or just plain old hypertension. Okay, and so that's going to tell us that they also are having some trouble moving the blood through their body. We also might get a cardiac cath, which is going to detect the actual pressures within the heart chambers and the vessels. Before the cardiac cath, we need to check for allergies every single time. So, like, check if they're allergic to latex, because usually we use latex gloves and materials during procedures like that. Check if they're allergic to shellfish, because we use iodine to cleanse, and if they're allergic to penicillin, because a lot of times we might need to do prophylactic antibiotics, or if we are concerned about the patient's health status, we might need to give penicillin following the cath, just to help prevent them from developing major infections. All right. Further treatment, lifestyle changes. That is the biggest thing that they can do. Lose weight, start exercising, okay? And I know it sounds simple, but I mean, that's really the best thing that they can do to fix their life, and keep them from having any major cardiac events, is just change your lifestyle. Also, if they're a smoker, they've got to quit smoking, because that constricts the vessels and decreases the amount of oxygen that your body actually absorbs. Not good. Okay, and I love this little cartoon that says, what fits in your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? I mean, really, when you weigh it out like that, there's no question. Also, managing their blood sugar if they do have diabetes, that also will help. They might need to be on some medications as well in the meantime while they're losing weight and exercising. Nitro, beta blockers, ACE inhibitors, diuretics, niacin, folic acid, vitamins, all of these are going to help promote arterial vasodilation, which means they're going to help promote widening of those vessels so that more blood can get through them. They also might need to be on statins, which will help to lower the lipid levels in the body, and those need to be given every evening. They also might need to be on aspirin or heparin just to help prevent clot formations. This is a new procedure, and if those of you who are going to get to go to the Amarillo Heart Group, you might get to see this procedure done, but it's called EECP. You won't be tested on it, but it's really interesting because they hook them up to these machines, and you see in this picture, they put cuffs around their legs and wherever the vessels are damaged, and they basically sequentially inflate and deflate to help promote the blood flow, and it especially helps promote it towards the heart. Okay, it reduces angina, improves their exercise tolerance, but it is kind of time consuming because the client will spend 1 to 2 hours a week at a physician's office for 5 days a week for 7 weeks total. So that's a lot of time, but a lot of patients will opt for this instead of having major cardiac surgery or coronary artery surgery, okay, which I don't blame them. I would opt for that too. They also might have to have a PTCA placed, which is a percutaneous transluminal coronary angioplasty. We will talk about PTCAs quite a bit, okay, so I do want you to know what this is. But basically, they insert this wire that has a deflated balloon on the tip of it. They find wherever the plaques are, okay, the thickest portions of plaques, and they insert this wire in there with the deflated balloon. They inflate the balloon, and that pushes the plaques aside, which will then widen the vessel. It's really a very helpful tool that they can use. And then a lot of times you see this wired thing in there, that's a stent. A lot of times they'll leave that stent in place to keep it open, okay, and that really will keep that blood flow flowing well. We do need to remember to assess all distal pulses beyond the point where they placed the stent or did the balloon angioplasty, because we need to make sure that the blood is flowing through and that it didn't occlude it even more, okay? A lot of times they will also use a dye to just check for placement and make sure that, you know, it is flowing freely, and then they'll use a fluoroscope, which is kind of like an x-ray machine that they can see things while they're doing them on a screen. Okay, it's really cool. But so anytime they're going to use a dye or anything, we need to ask them if they're allergic to dyes. Some people know, some people don't, but it's good to ask. We also might do an artherectomy, and there's different types of artherectomies, but it's whenever they remove the fatty plaque that isn't soft anymore. So they'll go in, and a lot of times this is followed by the balloon angioplasty therapy, the PTCA, with a stent placement, that they'll go in different ways using either directional, transluminal, rotational, or laser You can read about these in the book if you want to. You're not going to be tested on these, but basically they go in there and they either like roto-rooter it, where they shave it off, or they laser it, or like drill it. Okay, but it gets all that plaque away and it's great. And then they leave the stent in place. They also can do a CABG, and I think y'all have heard of CABGs before. It's CABG is why we say CABG, but it's coronary artery bypass graft. We'll go into it in following slides and watch a video and everything, but it reroutes the oxygenated blood through a transplanted leg vein or a chest artery to below the obstruction. And when we watch the video, that'll make sense to you. But we'll take a vein basically from the leg, is the most common one. Take that vein, and wherever the clot was in the heart, they will remove that section and insert the vein from the leg to help the blood flow freely through. It's really interesting. Some people need multiple grafts if they have multiple arteries that have been damaged, but it helps to, I guess, restart the blood flow around the heart. They will need, during the procedure, they'll need an external way to circulate the blood and keep it oxygenated, because during the surgery, the heart is stopped and the blood flow to the heart is occluded and stopped so that they can transplant those vessels. So they need to be on a bypass machine, which means the blood flow is moved to an external circulating machine. It's really interesting. The results are more permanent, but a lot more invasive than the PTCA. So this is something that's like last resort. Okay, it's something we don't want to do right away. We wait, make sure nothing else is working, and then we can go for this. And then there is something called TMR. I'm not even going to tell you about it. It's a laser procedure. A lot of people aren't candidates for it, but it's whenever somebody can't have surgery, the PTCA didn't work, they go in and they try to improve oxygenation by lasering out things. Okay. So as a nurse, we need to educate our patients, bar none. Okay, with coronary artery disease, you've got to teach them to exercise and eat right. So that means you have to give them options. Tell them what eating right looks like. Okay, so stay away from fried foods. Eat more vegetables, high fiber, lean meats. Get their fruits and everything in their system every single day. Stay away from anything made with a lot of oil or with a lot of salt and things like that. Tell them to just go for a walk every day. If they walked 30 minutes to an hour every day, the weight would come off. Okay, and then their heart health would also increase. It's really not that hard. Okay, so we have got to educate people all about that. Also teach them to stop smoking. We might need to administer oxygen if their oxygenation status is poor, meaning that they are not perfusing well. Their oxygen is not going all the way to their capillaries and all through the body. We might need to manage some anticoagulants, teach them about the diagnostic procedures and treatment procedures and surgeries or whatever they're going to be going through. We need to teach them about them, the risks, the things that we need to check for, like allergies and everything. And then monitor for side effects of drugs or after the diagnostics or after the surgeries or treatment procedures or anything. Okay. All right, let's take a break and then we'll come back and talk about heart attack.